Good afternoon. I'd like to welcome you today to the 23rd Annual John Collins Harvey Lecture, which is sponsored by the Pellegrino Center for Clinical Bioethics here at Georgetown University. My name is Miles Sheehan. I have the privilege of being the director of the Pellegrino Center for Clinical Bioethics, a professor of medicine, and David Lawler Chair of Catholic Healthcare Ethics at Georgetown University Medical Center. A few words about Dr. Harvey. A distinguished clinician, researcher, medical educator, and a really nice man. He was a graduate of Yale University and the Johns Hopkins Medical School, and then he was a faculty member at Hopkins before his big career break happened, and he came to Georgetown in 1973. He was a leader in establishing what was my specialty, geriatric medicine. And Dr. Harvey was also a man of very deep Catholic faith, and in 1989 acquired a PhD in moral theology from St. Mary's Seminary and University in Baltimore. Dr. Harvey is a close friend of Dr. Edmund Pellegrino. Dr. Harvey worked as a faculty member with Georgetown Center for Clinical Bioethics until his death in 2017. Having had the privilege of meeting with Dr. Harvey, I got to have lunch with him one time. He was a guy that was incredibly warm, had a great sense of humor, and deeply erudite, but wore it very lightly. Our speaker today is Dr. Carlos Gómez-Vírseda, a physician and member of the Society of Jesus. He's also a priest. He served as head of internal medicine at Good Samaritan Hospital in N'Djamena, Chad, where he also teaches at the Jesuit Medical School. He currently works in pastoral care at St. Jean Clinic in Brussels, particularly in palliative care and oncology, accompanying patients at the end of life. He holds degrees in philosophy and theology and completed 2 master's degrees with excellence. One in bioethics from Comillas Pontifical University in Spain, and one in end-of-life ethics from KU Leuven in Belgium. He's currently completing his PhD at KU Leuven, focusing on conscientious objection to euthanasia and assisted suicide. He's spending 6 months at Georgetown to the delight of everybody. He's been a big hit everywhere he's gone. And he's doing this as part of his doctoral research. I'm afraid we're making him do so many things. His research is suffering, but we're all having a great time. So thank you, Carlos. His work combines bioethics with community health projects and teaching in medicine, nursing, and end-of-life care ethics. We'll have a time for questions after Carlos's presentation is over. And then the very last slide today will tell you about some exciting opportunities from the Pellegrino Center and the Kennedy Institute, including our intensive bioethics course in June and our upcoming Pellegrino seminar the end of April, as well as some other offerings. So without further ado, please welcome Dr. Carlos Gómez-Vírseda.
Well, I would like to begin by expressing my gratitude to Father Miles Sheehan for inviting me to deliver this lecture, and also to the Pellegrino Center staff, to Dr. Harvey's family. It's a real honor, and I truly appreciate your trust. As you may notice, English is not my native language, so please feel free to interrupt me at any moment if something isn't clear, and appreciate your patience in advance. In this lecture, I will present some reflections on our relational approach to autonomy in bioethics. But before we begin, I would like to make this session a bit more interactive by using this tool. Let's see. Let's see if the technology is playing against us. Okay, yes. So by using this tool, Poll Everywhere. So if you want, you can scan directly this QR code, both those who are attending the webinar and those who are present here. And we will use it as a tool to make this session a bit more interactive and hopefully meaningful for you. It allows everyone to respond in real time using your phones, devices. It's completely anonymous, so don't worry. and this will help me to know a little bit more about the audience. And now, if everyone has been able to sign in, we could start with the first question, just to know a little bit more about the audience. Okay. Good. So this helps. We see that half of the audiences are healthcare professionals. There are some philosophers, theologians, some students, and also some other. We don't know what it is, but we will learn about it soon. Good. Now that I know that everybody has access to this tool, we can start, and I will begin by introducing myself. As Father Miles Sheehan said, my background is a bit unusual. So hopefully this will help to understand what I'm speaking from and the examples I will be bringing. In fact, I combine 3 roles. I'm a medical doctor, but also a Jesuit priest and a PhD researcher. As a medical doctor, I have mainly worked at the Good Samaritan Hospital in Chad, Jamena, serving there as the head of internal medicine in 2013. And since then, I spent several months every year. Clinical reality there is very different, as you can imagine. We treat mainly infectious diseases such as malaria, HIV, tuberculosis, along with anything else that may come, like deliveries, surgeries, etc. And one of my main tasks is training nurses and physicians to run the hospital independently. In recent years, I have also published some public health articles along with local colleagues there. Many of them were my former students, something that I'm very proud of. As a Catholic priest, I joined the Jesuits in 2006, and during my formation, I've studied philosophy, theology, completed 2 masters in bioethics and end-of-life ethics, and I'm currently part of the pastoral care service at the Clinique Saint-Jean in Brussels, working mainly, as it has been said, with oncology and palliative care patients, accompanying them at the end of life. And this experience has been a source of inspiration for my research. As a PhD student, I'm currently writing my PhD dissertation at the KU Leuven in Belgium. Here you have a picture of that beautiful city in one of the few sunny days. And my research focuses on conscientious objections in euthanasia. You would see that many of my examples will deal with this reality. I'm not sure, and today I'm going to present my work on relational autonomy, and as I'm not very sure how familiar you are with this topic, we will make a brief journey together. From the birth of bioethics, something perhaps known for many of you, to more contemporary discussions. So to understand this emerging concept of relational autonomy, we will begin with some historical context. Let's go back to the 1970s, when several research scandals raised public concern in the US. Tuskegee, where African-American men were left untreated in order to study the natural progression of syphilis, and also Willowbrook, where children with disabilities were infected with hepatitis under the claim that they would likely get it anyway. In response, the government issued the Belmont Report regulating human research, and that same year, Beecham and Childress published the Principles of Biomedical Ethics. This work has been called the birth of bioethics, perhaps a bit exaggerated, but anyway, the book certainly had a big impact, in part due to its simplicity, applicability, non-dogmatic approach. As you know, both authors were professors at Georgetown University when this book was first published. And although widely influential, it also faced criticism. Later, Georgetown scholars like Edmund Pellegrino and John Collins Harvey took other paths and emphasized other ethical dimensions, like the moral meaning of physician-patient relationship and the importance of virtue in medicine. As you probably know, Beecham and Childress argued that bioethical dilemmas could be analyzed using 4 principles. And these principles were meant to be universal. That is, shared by all committed moral persons. These 4 principles were non-maleficence. So first, do not harm the patient. Beneficence. First, this compels the doctor to do what is best for the patient. Autonomy, respect the patient's rights to make free and informed decisions. And justice, to provide all individuals with equal access to healthcare services. And these 4 principles, as I said, were meant to be universal, shared by all morally committed people. In order to see how practical these principles were, let's apply them to the Willowbrook case. We can formulate an ethical question emerging from each of these principles. So first, the principle of beneficence. We could ask, is there any benefit for the persons involved, for these children? Non-maleficence. Do you purposefully harm the patient? Because it is not the same thing if these children already had the disease or you inoculate the virus. In terms of justice, why children with disabilities, right? And respect for autonomy, have they given their informed consent? So you see, hurrah for principlism. It has proved to be very useful for framing ethical discussions, but it also has limitations. Let's see this by doing a little poll again. I invite you to participate in this poll and to explore the limitations a bit further. Okay, imagine an ill patient experiencing unbearable suffering who requests medical aid in dying. This is euthanasia or physician-assisted suicide. As a healthcare professional, what would you choose? And interesting enough, we have a little bit of different views, right? Some people will respect the patient's choice, especially if I'm saying that the patient is experiencing unbearable suffering, he requests made without any external pressure, etc. And some people will not grant it because their conscience tells them that it's wrong. Okay. Let's see the typical case of a blood transfusion for a Jehovah's Witness teenager after a car accident. Imagine he's only 16 years old. What would you choose in this case? You will respect the patient's wishes and not transfuse, or you will act in the patient's best interest and transfuse. Here, the audience is a bit more divided, 50%, 50%. Most of you will transfuse. Okay. What about if I say he's 16 years old instead of 14 years old? You can change your answer. 17 years old, he's growing. What would you do? 17 and a half. Suddenly he turns 18. And we now respect his choice. Okay. You see how the answers are moving. This one is a tricky one. Imagine you are the health minister of the United States and you have $1 million. And you must choose. You treat 100,000 people with common diseases or only 10 people with a rare but severe disease. Okay. I see most of the people will try to treat as much people as possible. That's a way of thinking. Now, imagine that we are in the times of COVID and you have 100 ventilators only for 200 COVID patients in need of oxygen. What do you treat first? You can treat patients who are healthcare professionals. So you prioritize utility terms in those moments of crisis, or you can treat patients with Down syndrome, those who are more vulnerable. or you don't choose, just the first to arrive, first arrived, first served, right? It's difficult to choose, and I see that half of the audience is going for the easiest way. So you don't have to decide. And we finish with this one in terms of confidentiality. Imagine a patient who is diagnosed with HIV and he asks you not to tell his wife. What would you do? You respect his choice and not tell her, or you break the medical secret and tell his wife? Okay. Half of the audience will protect the wife, half will respect his wish. There are answers to these questions, but they are mainly legislative answers, not ethical answers, most of the times. So these examples show how principalism works. Yes, it does not solve every case on its own, but it provides a common framework, a common language to describe each of these cases as a conflict between principles. And we can now discuss which principles matters most in each situation. So in the case of MAID, for example, there was a conflict between the autonomy of the patient who asks you to end his life and non-maleficence. First, you don't want to harm the patient. In the case of the transfusion, there was a conflict between beneficence, you want to give the best treatment to that patient, and autonomy, he refuses that treatment. Third, in the case of allocation of limited resources, we have a conflict between beneficence, we want to give the best treatment to all people, and justice. We don't have enough and we have to choose. And finally, in the case of the professional secret, there is a conflict between autonomy and non-maleficence. Autonomy of the patient, respect his wish not to tell his wife, and non-maleficence, do not harm her. Okay, now notice, and this is important, that when autonomy conflicts with other principles, most legal frameworks prioritize autonomy. And this is a legislative choice. It's not an ethical judgment, but it does not mean that autonomy is superior to other principles. In fact, Beecham and Childress never proposed a hierarchy of principles, as you know. But yet in practice, laws often privilege autonomy over other principles. And this is why autonomy is so important, and we will examine it in detail. We move to autonomy, to the respect for autonomy. And of course, it did not originate in the 1970s. It is the result of centuries of philosophy, from Descartes, the primacy of the subject, to Locke, the individual protected from the state, Kant, the person treated as an end and never as a means for other things, and John Stuart Mill saying that the only limit for individual freedom is preventing harm to others. Autonomy led to key changes in medical practices, like the regulation of non-voluntary human research and overcoming medical paternalism. As you know, medical paternalism is like, in the past, doctors did what they considered to be best for the patient, and now we think that patients have the right to actively participate in decision-making and refuse treatment. So autonomy has also helped to develop patients' rights, practical tools like the informed consent, the central expression of autonomy, and advanced directives that allows patients to guide future medical decisions. We come close to autonomy, and we see that mainstream interpretations of autonomy has said that for an action to be considered autonomous, the patient should be competent, well-informed, and free from external pressure. Competent means the capacity of a person to act on his own behalf, able to understand information, to use it, to communicate. Well-informed by the doctor, who's supposed to provide with neutral information, and free from external pressure. It is the patient alone who should decide without any undue pressure, manipulation, coercion, or medical paternalism. But now we question, is this enough? Let's see this by a simple case. Well, simple, not simple, but a real case inspired by my experience with end-of-life patients in Belgium. Imagine a 45-year-old man with a malignant cancer. He has no partner, no children, and he has the intermittent support from his sister. After chemo regimens, he's admitted to palliative care. He's cognitively intact or oriented, and he wishes to remain actively involved in decision-making. Well, he's experiencing little by little progressive decline. His symptoms are mostly controlled, a bit of edema, a bit of ascites, but he presents some emotional lability. This is like up and downs, and some episodes of confusional syndrome, becoming disoriented at the end of the day, something very normal in this kind of patients. So aware of his terminal prognosis, he requests medical aid in dying. Mr. Philip is a religious person, so he asks for an interview with the hospital chaplain, and after a meeting with him, he withdraws the request. A couple of days later, following a severe rectal bleeding and a heated conflict with his sister, he restates the request for euthanasia. This case is inspired by real-life clinical practice in a country like Belgium. Okay, now I ask you, you are the medical doctors, and I ask you, what do you do next day morning? Do you follow Mr. Philip's last decision? Well, some of you will follow his last request, but most of you will not follow this request. You think that Mr. Philip needs some time to make up his mind, right? Okay, but Mr. Philip has passed a cognitive test. Do you think he's competent? Well, some of you says that he understands information, he thinks he's competent. But some says that, okay, his conscience is fluctuant. He repeat the test. We should repeat the test in a clear mind moment. And some of you think that he's too emotional. He cannot decide like this. 1/3 for each. Okay. What do you think? Is there any external pressure coming from the priest or the doctor or the sister? Well, something that Mr. Philip is free enough, something that no, that each participant is playing its rightful role, and something that we need an external person to judge about this. And this could be even more complicated. Who would be that external person? So finally, which principle do you follow in this case? Would you follow autonomy, full respect of Mr. Philip's wish? Do you follow beneficence? As euthanasia is irreversible, better do not perform this in this moment, or we try to find a consensus, preparing a meeting with the priest, the doctor, the sister, patient. Well, now we can advance and see that real-life situations, as the one that we have seen, confirm many shortcomings in the mainstream interpretation of autonomy. First, that we are more than purely rational capacities, that Mr. Philip has passed a cognitive test, but his decision is constantly changing without any new technical information indeed. Second, that we are not islands, that Mr. Philip is supposed to make decisions on his own after receiving neutral information, but he's asking for guidance and help. Third, that autonomy is not a binary all or nothing notion. Mr. Philip is neither perfectly autonomous nor not autonomous at all. It's something in between, like compromised or limited autonomous. And four, that autonomy is more than isolated discrete moments of choice. Mr. Philip has signed a paper, and then should we stop the timer then? Is this his last and definitive decision? So on the contrary, against these four shortcomings, we see that we have multidimensional capacities, that we are persons in relation, that autonomy is rather a gradual notion, scalar notion, and that we need a time-extended perspective. Let's see them one by one. What do we mean with multidimensional capacities? Well, doctors tend to focus on technical information. Some studies show that they normally give 20 bits of information to the patients per contact. And we know that emotions are part of decision-making too. We saw it in the example of the argument or the discussion with his sister that our body speaks to. We saw this in the bleeding that scared him, that frightened him, and that religious beliefs can help patients to make meaningful decisions about care. And they are not always irrational. So good decision-making should include all these aspects. It's not only about cognitive capacities, but should include all these aspects. Second, we should find new roles for a relational environment. Look at this triangle. We have the patient at the center, but the patient interacts with healthcare professionals. He also talks with the family, with the priest, and all this is embedded in a certain social and cultural context. So relational authors insist that healthcare professionals should engage in shared decision-making, should not leave the patient alone, and should provide guidance, help, based on their knowledge and the relationship with the patient. Also, family and friends have a role and can help patients to make meaningful decisions. They should not only be seen with suspicion, and here there is this notion of mutual responsibility. I don't fully agree with what John Stuart Mill was saying about that the only limit to individual freedom is preventing harm to others. The Catholic social teaching rather says that life is not an individual good, it's rather a social good. We receive life, we receive language, we receive education, and in that sense, it's difficult to claim that decisions affect only oneself. Choices about life and death always have consequences to others or for others, and so there is a mutual responsibility in every of these decisions. We can speak about that later if you want, and all this is happening in a social context. It's not the same to make end-of-life decisions here in America or in Spain or in Africa, the way we treat and value sick people, the elderly, because many times they feel like a burden to society. And if this is becoming one of the main reasons for asking euthanasia, there is a kind of social as well, social responsibility to deal with this kind of reasons. 3, autonomy should be seen more like a gradual concept. Autonomy sometimes is seen as an all or nothing affair, like if you are competent, well-informed, and free from external pressure, then we follow every decision you make. But if one of these conditions is lacking, then someone has to take decisions for you. Who? The priest, the sister, the doctor, the judge. I think that there is a big gray zone here in which we can consult the patient, we can ask him to participate, but not follow every single decision if we think that it has not enough moral weight. Patient's autonomy should be balanced with other principles, like responsibility, the doctor's responsibility, especially when the patient is in a vulnerable situation. And finally, we need a time-extended perspective for autonomy, because many times autonomy is exercised like in discrete moments of choice. It starts and ends with a signature on a paper, and then we should stop the timer. This is your last and definitive decision. Well, decision-making is rather a process, and decisions evolve over time. They can be reconsidered, they can be revisited, and decision-making happens within a dialogue between the patient and the physician. The important thing, what matters, is that decisions remain coherent with the patient's life story, biography, values, etc. So all these 4 aspects have been treated by relational authors under the concept of relational autonomy. And we see that this concept is gaining significant attention across literature. We see it in top journals like Nature, Mental Health, Nursing Ethics, artificial intelligence, post-colonialism, feminism, or conscientious objections. We see it everywhere. We can speak about a relational turn in bioethics, like a trend of recent publications, but also important misunderstanding. And this is why during my research, I have tried to answer to these questions. First, what are the meaning, foundations, and uses of relational autonomy in the end-of-life care ethics, and how this can be operationalized in a more practical way? The first question was I tried to answer in this article published in Biomedical Ethics, a systematic review of argument-based literature. This is a highly standardized method. We search in 8 databases, identifying more than 2,000 articles, and then after screening titles, abstracts, and full texts, we synthesized all the relevant literature. And these were like the main 3 conclusions, which I think they are important for this topic. The first, that relational autonomy was often a reactive concept. It's rather like a critique against a narrow interpretation of autonomy rather than a positive concept on itself. And we see here a tendency toward oppositional thinking, like individuals against relational authors. And we need a strong anthropological foundation that considers that there are no individuals without relations and the other way around. Then that relational autonomy was a concept emerging from multiple sources. And we see here feminism, Christian personalism, care ethics, virtue ethics, non-Western ethics. But there is very little dialogue between them. And finally, it's difficult to operationalize. It's difficult to bridge the gap to fill the gap between theory and practice. And this is what I try to do in this second article about relational autonomy in a contextualized approach to end-of-life realities. Here you have a summary or a condensed version of the procedure I have tried to develop in the article. Imagine the first step would be like the healthcare team drafting a best interest plan based on a time-extended dialogue with the patient and between the patient and the multidisciplinary team. Okay, then the patient makes end-of-life decisions and we compare them with a plan. If it's aligned with the frame document, the decision can be honored. But if not, autonomy should be reassessed, reevaluated in the light of the patient's core values. So the decision moral weight is reviewed, and if some criteria are met, we can accept this as an authentic and stable decision, even if it conflicts with the plan. But if not, we consider it not compelling and further dialogue is required. It sounds complicated, but it's more or less what we have done in the case of Mr. Philip. So some comments on this procedure. It's a prudent approach that balances autonomy with other moral and professional principles like responsibility, vulnerability, etc. It's guided by a logic of care rather than blindly adhering to a logic of choice. So it legitimates some interference with personal choices, but under certain control. It allows some interference, but under certain control. And some would say that it's a complex and time-consuming procedure. Yes, but I think that similar procedure is commonly followed, though implicitly, that perhaps a formal written assessment may apply only to relevant end-of-life decisions and not to every single decision. Anyway, relational autonomy as a lens for complex issues, I have been writing several papers applying this concept to various ethical situations like COVID-19 or euthanasia in persons with advanced dementia. And hurrah for relational autonomy, it works, it can help, but nevertheless, there are persisting questions. I know that it's still difficult to operationalize. And let's finish with this last poll that will help you to see the difficulties that we encounter with relational autonomy as well. Disclaimer, I'm playing with stereotypes here, but imagine this old man, terminally ill. He would like to receive euthanasia, but his adorable wife wants to take care of him till the end. He agrees. And what do you think here? That he should receive euthanasia? That you would try to talk to him privately and convince him that this is his choice? Or he should not receive it? It is his true desire to respect his wife's wish. Okay, as expected, 90% of the audience think that this could be a legitimate choice. Now, consider this other case. A young woman with terminal cancer who is in pain, and her husband, wicked husband, does not accept morphine because of religious beliefs. After a discussion, she gives in. What do you think? Do you think she should receive morphine? Or that she should not receive morphine? Because her authentic wish is to respect his husband's wish. So here, suddenly we have changed the numbers, right? Yes. I said it, I was playing a little bit with the stereotypes, but it's true. There are some similarities in these two cases. Both patients are suffering, both have made a decision, their partner would like something else, and in the end, they are both persuaded by their loved ones. But there are differences too. We react differently depending on what we think that is good for the patient and what we think that are healthy relationships. And here, I agree, relational autonomy still demands a concept of what is good for the patient, what we consider healthy family dynamics, some shared cultural values, and who is deciding all this? A virtuous healthcare provider, probably. So in this sense, I agree with Dr. Pellegrino and Dr. Harvey that we need a broader approach to complement principalism. And thanks to my work at the Pellegrino Center, I have become more familiar with their work, and I have found strong resonances with the concept of relational autonomy. For example, when they say that medicine has a telos, as a goal, and this is the patient's good and not just respecting the client's choice. Or that the clinical encounter is always ethical, that is not merely technical. That medicine depends on trust, and that the patient's vulnerability are creating obligations on doctors. That virtue is essential for clinical judgment, and not only in exceptional cases, but in everyday clinical practice. And finally, that beneficence in trust, their concept resonates strongly with the concept of relational autonomy. Let me finish with this intuition and tell me if it makes sense. We can imagine now two paths or two models that ultimately converge and show significant overlap. Both models emerge in response to the profound scientific, technological, and social changes that transformed medicine in the 20th century. Beecham and Childress developed principalism, placing a strong emphasis on respect for autonomy. Their initial focus was on patient-centered decision-making and individual choice, while Pellegrino and Harvey developed the beneficence model, emphasizing physician's responsibility, and their initial focus was the duty to seek the patient's good. Over time, both approaches have evolved and self-corrected somehow. Principalism has moved toward a more relational understanding of autonomy, and we heard Childress talking about this yesterday, and I think that relational autonomy avoids a purely individualistic and non-realistic view of decision-making. And beneficence in trust avoids paternalism by integrating the patient's values, patient's autonomy, and active participation. So relational autonomy and beneficence in trust show a strong overlap. They both converge towards a shared relational space where decision-making happens. One begins with from the patient's perspective, the other begins with the physician's responsibility, but both finish perhaps in what Pellegrino called a covenant, between the physician and the patient. This is my interpretation. I leave it open to discussion, and I would be very pleased to hear your comments, as you know these authors much better than I do. So I finish with this. Reality is very complex, and it's better perhaps not to stick to a single perspective, but to use them in a complementary way. Principalism can provide clarity, but a kind of paternalism or beneficence would always be present in medicine. Deontologism can provide some guidance. Utilitarian perspectives are always useful and democratic. Catholic social teaching brings some essential principles like dignity, solidarity, the common good. Virtue ethics is necessary for clinical judgment, not only in exceptional cases, and care ethics reminds us of our vocation, our call. So don't stick to a single approach. Instead, we combine them all, and only by doing so we will be able to respond to the complex ethical challenges that we are facing today. So thank you very much, and I would be very happy to answer any question you may have.
Thank you very much, Dr. Carlos. That was a wonderful presentation, and I know that people will be thinking a lot about what you've said. We have a couple questions that have come in, and one of the questions is, what about the autonomy of healthcare professionals? We usually analyze the competence and autonomy of patients, but we neglect the other side of this pair. What would you say about nurses, physicians, and given that you've talked about conscientious objection, or that's what you're researching, what do you think about that?
Well, I think it's an interesting question, and I think it's answered more or less with the last slides where we speak about this covenant in Pellegrino's terms, but we can think about this shared relational space where we don't focus only on the patient's autonomy, but we take into consideration as well. The question is about the autonomy of the doctor, yes, but also his responsibility or her responsibility, not only doctors, but healthcare professionals, their responsibility, the care, all the other principles that come into stage. I think that this, we can understand that coming from paternalism, the pendulum moved very far towards the autonomy of the patient, and that made sense during a certain time. But now there are these corrective movements that try to bring the pendulum a little bit more on the other side. And we spoke about relational autonomy, but we spoke about the beneficence model and Dr. Pellegrino and Dr. Harvey insisting on this. And we have many other examples like care ethics and many others. Yes.
Another question that has come in is, how do you think the best way to work with patients to consider moving from an exclusively personal autonomy to accept the concept of relational autonomy?
So, yes, I guess this question is trying to bring the cases in which people do not only make decisions for themselves. We know that there are many cultures that privilege other ways of decision making. I said that many of the publications about relational autonomy come from non-Western perspectives, and in that sense, many other cultures and places are saying that there are other ways of decision making, and that it's true. This bioethics that had been developed mainly in the United States and in America places a strong emphasis on individual autonomy, and that is a very precious value. But there are other cultures that would value other considerations like family harmony or communitarian ways of decision making. Well, this is a challenge, honestly, because with the tools that we have, like informed consent and so on, it's difficult to bring other voices into decision making, and this is something I think that we need to develop further. With in the Western context, I think that the procedure I have presented is a middle way, an in-between approach that gives weight and hears and puts the patient at the center, but also gives voice to other considerations like the doctor's responsibility, what they think that is best for that patient, but also the family coming in and so on. So that procedure I presented there can be seen as a concrete procedure for Western settings in which we try to bring them in the conversation, respecting at the end the patient's choice and just making sure that it's coherent with his or her own values, biography, etc., etc. But I think that in other contexts, in other cultures, it would be nice to challenge, to find other ways and to find other practical tools to make this relational autonomy operationalized in their context. And probably it is not us to give that solution, but hear them how they can implement these other ways of decision making.
Could you comment a little bit on how to assess and respond to what could be legitimate third-party interests? Example, like family members who are overburdened with caring for a patient.
So that's a good question, and I try to emphasize this with the last poll we did, in which we saw an example of family member who was considered like a healthy relationship. She wants to help this person at the end of the life, and we 90% of us, we consider that was rightful, and then we have this wicked husband that we consider that was not a rightful. So I think the solution was not in autonomy in itself. You need something external to judge that, and I recognize that we still need a notion of what is good for the patient, some common shared values, what we consider a healthy family relationship, and this has to come from outside of the picture. And that is fair enough. That is why I said that I think that we need some complementary views to judge that and to try to decide. In the procedure I presented, it was done in a way that we hear the family and what they have to do, or the worries of the healthcare professionals, but at the end of the day, we try to respect and to hear the patient's voice, who is the one who has to decide. We just want to be sure that the triangle is heard and that everybody has a word on that.
I'm wondering to what extent this concept of relational autonomy either should change or inform what we would understand as informed consent.
Yes, and well, this is a difficult question, and there are many other experts on the topic. I honestly think that we should work it, and I have not done it. It's a very specific thing with experts on the field that should develop this practical and legal tool. I was talking from a ethical perspective, how these relations matter and should be heard, but then you have to translate it into legal tools, and I think that is something to be done still. And I once again refer to the procedure I presented, which is compatible with a physician with informed consent. It's only a procedure to make to operationalize the hearing of these different persons, letting the patient decide at the end.
You know, one of the things that people have talked about with professionalism and the concept of medicine or nursing as a profession is that professions have part of their role is to stabilize values within a society. There was a book 25, 30 years ago called Habits of the Heart by Robert Bellow, which talked about a breakdown, at least within American society, of ways in which people would come together and acknowledge that they were in relationship with each other. And I think part of the thing with relational autonomy is sometimes we run into people who are such rugged individualists that they don't want to be in relationships. Occasionally, this is not the main thing that goes on, but people with life-limiting illness, good palliative care, simply want to have their life ended at that point. Do you think that what you were suggesting could lead to another way to look at how the professions could sort of help us stabilize what seems to be the atomization of individuals in Western society and call us back to a way in which it's not paternalism, but we do acknowledge that we are in certain ways related to each other?
Yes, yes. I think that this concern is coming from very many approaches, and this concern of having atomized and isolated the patient in the decision making, like you are supposed to make decisions on your own with once you have been provided with neutral information, and we see that this is difficult, and the criticism is coming from many perspectives. I know the beneficence model, I know virtue ethics, feminism ethics, and many are highlighting this phenomenon, and I think it has to be acknowledged, and we have to refine the good things that we have reached with principalism, with respect for autonomy. There are many good things, and how to refine them in a way that make them more human, because humans are also relationships. So probably this goes back to the anthropological foundation of the person, of autonomy, if it's only an individualistic view, or we can find a way of thinking about persons and human beings as relations as well. And yeah, so when I hear you, I see that there are many voices claiming more or less the same kind of corrections from different perspectives. I have presented the relational approach, but also I know that there was coming from virtue ethics, Dr. Pellegrino, and the one that you have suggested. Yes, yes.
So I want to thank our audience today on the webinar for being with us. Again, we'll be having a slide that'll come up in a minute showing some of the offerings that will be available over the next month or two, including our intensive bioethics course with the Kennedy Institute in June and our Pellegrino seminar at the end of April. So thanks so much for your attention, and really grateful for being with us. And I want to thank Dr. Carlos. A personal note, it's wonderful to have another Jesuit doctor next to me. And for the people who are on the webinar, you must think that this is crazy clericalism. It isn't. Carlos said, "What should I wear?" And I go, "In the United States, you wear a collar when you're a priest and you give a talk." And so thank you. And I'm sorry if it was a little bit too Roman today, but that's the way it goes. So thank you so much. Bye-bye.